that is just so insulting to a medically trained doctor to be forced to code their own stuff because the company that we worked for would not pay for your scribe. If you want to scribe, you pay for it yourself. Like just silly things where it's like you feel devalued.
Are you sick and tired of the high costs and inefficiency plaguing our US healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I am joined today by none other than Dr. Maryal Concepcion. Welcome to the big show, Doctor.
Thank you so much for having me, Ray.
Oh, awesome. Awesome having you here. So tell me a little bit about how you get involved in medicine. Where do you get the bug? Where do you get the itch? Does it start very early? And I'm always fascinated about the journey because typically you don't end up where you started and vice versa. So how did it happen for you?
Yeah. So I love this question. It makes me appreciate where I was and where I am now. For me, I would say that growing up in a family of people who were very passionate about being a productive member of society was driving my culture. So I am Filipino by heritage. And when I am surrounded by people who are first generation immigrants to this country, being a hard worker is definitely just part of our genetic makeup.
It's not optional.
And yeah, it's not an option. And if you're a lazy Filipino, like you will get told that, like, what is wrong about that? And so for me, getting from an early age, like helping out with each other, helping out with each other's careers, whatever we can do to support, helping pay people's for education, helping make sure that if somebody needed help, that we could help them in whatever way we can, basically. And so that really, really led to finding a career in service. So I was also limited in terms of innovation when it came to career choice. The options were generally under the themes of doctor, teacher, lawyer. Which one are you going to be? And
No
I
pressure.
definitely, yeah, I found myself when I was 14 teaching zoo camp at the Sacramento Zoo. And that was really developing curriculum and having groups of kids and teaching them over a week's time based on a particular subject. And that was interesting for me. It was fun, but I didn't really like the curriculum development part of what I was doing. And so the lawyer and doctor options were on the table. And so throughout undergrad, I explored through our career center that I was very grateful that we had at UC Davis, different options in service opportunities. So I participated in being a volunteer at Child Life. It's an area at the UC Davis Children's Hospital where it's basically a place of respite for kids who are in the hospital. And what I took away from that was here's these kids who are so sick with some of them terminal illnesses, and they were happier than some of the people that I knew who didn't have any illness. And it was amazing to see the resiliency and just optimism, even in the face of, I know my life is going to be shorter than most people. I was able to volunteer at Shriners and the genetics clinic there in Sacramento as well, the pediatric emergency room. And then one of the most impactful opportunities for me was working with an in-home pediatric physical therapist, Amy Jorgensen. She's so important to this day, but she really showed me, like, when you are able to sit down with a family and in the home of these children, no matter if it was cerebral palsy or if it was a debilitating issue from a genetic disease, whatever it was, or genetic diagnosis, excuse me, whatever it was, Amy was able to really show me, like, this is where you can really do personal care. And I would get in the car with her and we would go to it was like day school for people who were not able to be at a daycare and with in the typical daycare setting, but these were people who needed assistance feeding, bathing, toileting, those types of things, as well as visiting kids in their homes with their parents right there. And so all of these experiences really opened my eyes to, I really do like the healthcare aspect of the career choices that I am looking to. That's what I was thinking at the time that I was at UC Davis. And when I was at UC Davis, I had thought about being a physical therapist because of my experience there. And then I had thought about doing other things in the healthcare realm. But what really opened my eyes was when I got into medical school at Creighton University in Omaha, Nebraska. The thing that really solidified my journey into family medicine was that I was very fortunate to go out to a town of 2,000 people, Superior, Nebraska, where the main care team was they were led by family physicians who were able to do C-sections and colonoscopies and everything that a primary care doctor is trained and able to do, less so these days because the training is not necessarily there all the time. But in one of my dear mentors, Dr. Tim Blakey, who graduated Creighton in 1979, he was trained in all of these things. And so for me to have the drive to go to medical school, the ability to go to medical school, and then also to see a doctor be able to deliver that personalized care that I saw, that I loved, that made a difference in people's lives generation after generation, family medicine was it. Like I was like, yep, this is what I'm doing.
That
And
is
so
so cool. My wife is binge watching Virgin River. I don't know if you've seen this or not.
that's actually really funny. My girlfriends joke that I live in Virgin River because there's a I live in Arnold, California, which if you look on the map, it's if you triangulate between Yosemite, South Lake Tahoe, and Sacramento. But there's areas on our one lane in each direction highway where the phone calls will drop. And so they'll say like, oh, she's entering Virgin River. Just call me back when you're done. So that's but
And when I say she's binge watching, it means that we are binge watching. I'm into UFOs. I'm always curious about the UFO stuff. Turn that shit off. Put on Virgin River. So yeah, that's what's going on in our house. But that
love
is
it.
so cool. And so you gave me a lot to unpack there. So catch your breath for a second.
Yeah.
It blows me away. A lot of what you said blows me away. Just first of all, being blessed with a good family that instilled a good work ethic. I think that is so important on just getting young people on the right path. And
Yep.
that's something that really resonates with me. And then being in an environment where you are surrounded by kids that, I mean, talk about a bad day at the office. It's like these kids are literally in a life or death situation, many of them with terminal illnesses. So the clock is literally ticking. And it's so touching that your experiences, some of these kids have a bigger smile on their face than just about anybody. And that really touches me because I think in the day to day, in the rat race of our lives, we tend to forget. We focus on all the bullshit, right? All the bills and the this and the that, and I got to be here and I got to be there. And you just slow the music down. You check what's going on in one of these kids' lives, and the
Yeah.
fact that they're maybe it's ignorance, maybe it's just a higher level of intuition, knowledge that just has them insulated from all of that, and how refreshing. So I just wanted to touch on that. And then being in a small town and having the ability to learn from some of these mentors that you're citing, and not just in a one dimensional way, but in a full 360 degree way of getting to put your hands on a patient and treat them holistically. That's what I'm hearing, at least. That's incredible.
I'm very grateful that I have so many like if you talk about how can you make healthcare better, like one as a direct primary care physician myself, and I know we'll get into that, like I'm very much more able to see more of what I loved and what I picked up on that drove me into family medicine than if I had stayed in fee for service. And it's ridiculous how just simple things like checking up after sending a person with an antibiotic, "Hey, how are you doing?" Like, it makes a difference in a person's knowledge that somebody is actually caring about them who has medical training. It makes a difference in the trust in that I can actually access healthcare when I need it. And so I
So wait
think
a
about
second.
all
You actually call a patient after you prescribe an antibiotic and you say, "How are you doing?" This is a thing. This actually happens.
so it's not necessarily always phone calls, but definitely there's messages that go out to a patient to check up on them. I mean, like I have a very, I love especially my older patients who are like, they're 90 plus years old and they look like they're 70 and they're just like, I still downhill ski, and I'm like, "Oh my god, the snowboarders, watch out for the snowboarders," but it's amazing that the feedback that I get from them is especially if we look at, like, cardiovascular issues, if a person has blood pressure that's all over the place, they have a rhythm, heart rhythm that's all over the place, that I'm able to work with them much more personable in a much more personal manner than I ever was in fee for service to be able to monitor. Like, I will call my patients or get in touch with them to say, "Your weight is going up. Did you notice that? Like, what's going on? Have you been eating out, drinking more water? What's going on?" And they're like, "Oh my god," like, that definitely happens where it's like patients are like, "I didn't think that I had an appointment with you." It's like not a matter of did you have an appointment, it matters that I'm taking care of you, and that doesn't happen sporadically throughout the year.
So how does that happen? How does that happen though? Are they wearing or devices? Are they logging into MyFitnessPal or how are you getting this data?
Yeah, so different ways. Definitely there's wearable devices and sharing data through wearable devices. But then there's also just even basic like logging their own vital signs. So we can trend, especially like I have a person who, like I mentioned with weight, that is a sign that has really big importance for things like cardiovascular disease, like congestive heart failure. If a person is having hypertension that's going uncontrolled, it behooves me to then ask like what is the reason. And so the tracking happens in whatever way we need it to that is affordable and accessible for the patient,
Mm.
and because I just get to be a doctor, I don't have to justify any of my work with codes. I can be nimble to literally use whatever tools we can have on the table to get the job done.
That is
So,
so
it's a very general statement, but it's really representative of when you allow the doctor to just be a doctor, you really get better care.
Now, how is it different? So you mentioned that you worked in a traditional setting as a doctor prior to
Mhm.
making the break and starting your practice. What did that look like? What did a day in the life look like when you were working in quote unquote the system?
Yeah, so I worked in fee for service, the system, for a few months shy of 6 years after residency. And so in residency was really where in medical school, I'll take a step back. In medical school is where I saw Dr. Blakey and what life was like as a medical student shadowing a family physician in Superior, Nebraska. In residency, I intentionally chose an unopposed program, meaning the family medicine residency is the only residency in the hospital. So we took care of the inpatient, emergency room people, labor and delivery, outpatient patients, pediatrics, dermatology, all of these things. It was a family medicine resident who was rotating in these clinics. In
Mm.
an opposed program, you have different specialties. And so opportunities to take care of patients in different settings is definitely less diverse. So when it came to residency, I was trained in the typical resident system that we have to this day, where you only know coding. You don't go into a visit knowing that you don't go into a visit being told that like just be a doctor, figure it out just like you did in medical school. We'll go over it because you're a first year, then second year, then third year, and you get more confident as you go on. It was always under the guise of what code justifies this visit. And so we were trained with if you see hypertension, it's this code. And you look at doctors, we are definitely as a culture rule followers when it comes to we go to medical school, they tell us the next 2 months we're studying the kidneys. The next 2 months we're doing this. Okay, now you're going to this rotation, you're going to this clinic at this time, and da da da. So we're very regimented in that sense. So
Hmm.
when it came to residency, I was definitely not one of the people who questioned, like, why is healthcare being represented by codes when there's no code of prevented diabetes or prevented hypertension. So then when I went to fee for service, it was a natural, nobody had, I do not have any entrepreneurs really in my immediate family. And so being a person who is a rule follower and also wanting to be helpful and contribute to society, I went into an employed position. Now I chose a position that allowed myself and my husband, who's also a family physician, to do what's called a job share. And I had never heard of this term until residency, where basically two people work the hours to make one full job. And we did that intentionally, one, because we wanted to have a family at some point, and we had seen so many attendings who they lived in different states than their kids. They didn't know how old their kids were. It was just like eye-opening to see we do not want to be like that. We want to be able to actually be in our kids' lives. So we intentionally only worked half time a piece, but even halftime without kids was not halftime because you look at all of the hours we spent trying to coordinate care, which there was no code for the stuff that we were doing, talking to relatives in other states because they had questions about their relatives that we were taking care of that they couldn't easily visit. When you had, like, I wanted to use my point of care ultrasound to be able to figure out if a person does have a DVT so they don't have to go to the ER. And there's so much pushback of like, oh no, we have to vet that. I snarkily say it didn't make it past the 16th committee to get the approval to use the ultrasound device. And so, like, we have ways of improving healthcare without spending more dollars. It actually drives costs down, but that's not in the interest. And that's what I saw in fee for service is like the interest is not actually to take care of patients. The interest is to get as many numbers. I also joked in one Medscape article that I wrote, it's like how many Chuck E. Cheese tickets can you get during your visit to Chuck E. Cheese? That's what the game was in fee for service. And I became very jaded. I became very, what am I doing? What is this? Like, why did I go to medical school? I did not go to medical school to ask people, like, do you wear your seatbelt? Like, that does not require me at my level of training. There should be no, like, in my head now, especially as a DPC physician, like, that is just so insulting to a medically trained doctor to be forced to code their own stuff because the company that we worked for would not pay for your scribe. If you want to scribe, you pay for it yourself. Like, just silly things where it's like you feel devalued, you feel like you're gaming like all the time to try to get as many Chuck E. Cheese tickets. And the patients are like pissed off at you because they can't get in. So they have to go to urgent care anyways. And do you know how much they had to pay for that? It's like, I am trying my best here and I can't try hard enough because I'm working with a system who does not actually want to help the doctors nor the patients.
How frustrating and demoralizing. How many patients were you seeing on your caseload in that setting?
Yeah, so I definitely would say that this is a level of frustration that still is like, it's not as frustrating because I'm not in the moment any longer, but it was like trying to even figure out how many people were on our patient panels was not a transparent thing.
Yeah.
So I would say for my visits, I was always trying to push for at least half an hour visits to an hour and a half, but that the way fee for service works typically is you get these what we call the golden handcuffs. So you start off, they're like, oh, like there's certain companies in California, we'll give you a 7-year mortgage on your house and we'll give you $1 million, like not literally, but a ton of money, more than you ever made in residency,
Hmm.
just for a sign-on bonus. And then if you do this, you'll be a partner. And if you do this, you do all of these things to try to get you into the pot. And then what happens is it typically transitions. We see contracts transitioning to relative value units. And that's where the codes come in. So the more code, the more money you bring in, but that doesn't mean you're going to get all that money. That just means that's the amount of money that or the amount of Chuck E. Cheese tickets that you're getting in
So
during the day.
these RVUs is essentially it's a measure of how much revenue you're driving for the healthcare system that you're a part of, right? They're
Just
measuring your performance and you're being held to a standard. So essentially, they're making physicians glorified commission salespeople.
Yeah, and even there, it's like we're being graded on how many codes we put in. So there's data to show that a female physician undercodes significantly less than her male counterparts. And when it comes to the idea of like my quality is being measured on how many codes I put in, that's ridiculous because it's like my quality of care, if you ask my patients with their like verbal feedback, would be like, no doctor's ever actually listened to me before. Like, I was put on this antidepressant and nobody actually asked me why I was depressed. I was just given it, but you actually asked me why I was depressed. This is ridiculous. So, just the basis of a doctor is graded on how many codes they're bringing in, and that determines their worth. Absolute BS. Like, when it comes to, like, we look at family practice, if you have a good relationship with your family practice doctor, your lifespan increases. But that's not represented by a code. And so this is why it's so fundamentally wrong that we have this representation of what we do by how many codes we can put into the computer.
Mm,
And that's how many codes that we can personally put into the computer again. Like, it just
yeah.
irritates me so much that it's like in Superior, it was The doctor goes in, you dictate your note, or the people that I knew one-on-one who would type up your notes and then flag you down in the hallway and be like, we didn't add a code for this. Can we talk about this? Can we add this code? Like there would be people to help out with the administrative things, but
Right.
not in corporate medicine the
Yeah.
way that I experienced it.
And am I
So
hearing you right? You're saying that your male counterparts would do a better job at coding and layering than your female counterparts? And do you think that's a product of, I don't know, let me not be kind, them just being assholes? Is it that your female counterparts have a conscience and or just not about the RVUs? What drives that?
yeah, I think part of it, and this is just me speaking from my experience where this was definitely true in our clinic, like my husband and my practice as doing a job share. For example, in the time that I was postpartum breastfeeding my baby, I'm like, I got stuff to do. I have to clean my pump. I have to like figure out what's the plan for food. What food do I have to steam and grind and prepare? And then I have to be a doctor and finish my notes. And then I have to do like yada, yada, yada,
Oh,
hashtag life. And
yeah,
then it's like, I don't care. I just need to be done. Hypertension, diabetes, that's it. So
right.
I think that for me, the experience was
Hmm.
the amount of things that I had to do as a woman definitely were different than the amount of things that were demanded of a male, especially in the postpartum journey that my husband and I had. It's like, yes, he could have cleaned parts, but it's like, ain't nobody like breastfeeding the baby in this house except for me. And
No,
so,
valid. I mean,
yeah.
that's true. It's a truism. You're not, this is like the reality.
Oh, sorry, just to put one last thing in there. I don't think it is the intentionality of like, I'm gonna add one more code. I mean, sure, it sounds spiteful, and I'm sure that people have done that, but in general, it's like, I think that there's the visits also with a female physician show generally, if you look at everybody across the board, are longer, and so we have less time to do the administrative stuff also. So it's a matter of a lot of things
Hmm.
that feed into that data in particular about female physicians coding less than their male counterparts. But when it comes to, I don't think that for the most part, doctors who are going to school to take care of people, I don't think that they're sitting there like, how many codes can I get? But I do think that there's that, and I've talked to DPC doctors who have done this, like where they feel that sense of like, what else can I code to get more money? Because
Hmm.
the codes are worth less if CMS cuts their rates. And so I think that is one of the things that drives people to say like, this can't be how we do healthcare.
Yeah. Well, it sounds layered to me, right? I think it's very real that you're in a situation where you're pumping, you're breastfeeding, you're da 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 da. Da. So you do have more on your plate than your husband, to use kind of a counterpart. I
Yeah.
think culturally, there's probably an element to it. And generally speaking, I find at least that women are better listeners than men. And so I think more empathetic, more dialed in, and they're going to take more time with their patients. Maybe I'm crazy, but I think all of that is kind of rolled into this rat race that is healthcare. And no physician should be in that position. I don't think it's the way, I don't think that's what you intended when you signed up to be a physician. It wasn't about coding, it was about helping patients,
Yes,
right? And
absolutely.
so you spent a good number of years in quote unquote the system. What was your aha moment? Because I'm sure it wasn't easy to break away from that, especially with all the incentives that they're throwing at you,
Yeah.
right? You're a young couple, you're starting a family, and oh yeah, honey, let's break out, go out on our own. That had to be like an oh shit moment, right?
Yeah. So very frustratingly, there's a lot of anger and just like righteous rage behind what happened to me in particular. The company that is a religious based company, that's the religious based clinic that we were at, where people think that like, oh, this is a religious, it's a very, yeah, faith based, like always for the pro patient, like BS
Profit,
situation. Yeah. That's quote unquote nonprofit. Yes. Love them to death.
aka non-taxed.
Yeah. The company we were working for had negotiations going on with us for a little over, I don't know, a year. I'm literally don't even know how long the negotiations took. But basically, when there was a corporate change of structure, the people who had been working with the physicians to bring them into the community to negotiate the contracts, it basically went to, we only have one contract. It's an evergreen contract. It will never change. And these are the terms. You either accept them or you'll, if you don't, you'll be fired as of October 31st. And this is 2020. I gave birth to my second 2020. So this was the fall of 2020. And
Wow.
like, great, have a pandemic, have a baby, have a
Oh my
threat
God.
to take your career away. Let's just do it all, man. Do it all and go home, go big or go home. It was just so flooring to me. And like unexpected that the corporation would basically get rid of all of the negotiation people who'd been doing this for 2 decades, in some cases, and just do away with personalizing the relationship with the physician. And so I was given this letter, I still have it to this day, like the former physician recruiter turned crony of the system, whose uncle is a physician, mind you, who has no soul. And I hope he hears this. I really hope that he's out there listening to this. But sent me a letter that said, "You're going to be fired if you don't sign our contract." And when a physician is in a rural situation and is family trained, full scope trained, you would expect that there would be different compensation than a doctor in the city who is only limited to seeing adult patients, no kids, no pregnant women, no procedures. And so that wasn't the case. We were constantly calling them out for, like, you're not even paying us standard rates. And then you're telling us that it's never going to be renegotiated. Like, oh, yeah, sign me up. Like, that amazing. So I tell people that you need to look out for evergreen clauses because it's very popular in corporate medicine, that we had rates that were not even fair, that we would be under exclusive contract, meaning if a pandemic happened or an earthquake happened and one of us was needed, that they would have the ability to say by contract, you're going to be needed in Los Angeles. And I'm like,
Oh.
but we have a baby and we have, like, we're married. But that's what they want to put in their contracts. It's just insulting. Thankfully, in California, we don't have enforceable non-competes. But in other states, my colleagues are facing, like, I can't even stay in where I want to practice because of a stupid non-compete.
Wow.
And it has nothing to do with the patients at the end of the day.
Yeah. Yeah. And I'm sure you didn't get any medical training when
No.
you were in medical school about the nuances of signing a contract and looking out for these evergreen clauses and for non-competes. And it really, based on what you're telling me, this is a vital part of your training.
Yes.
Okay, it
Yes.
has nothing to do with healthcare, but it has to do with protecting yourself and your livelihood because people just, and look, in I don't want to insult anybody out there who's listening. I interview a lot of doctors. Most doctors are terrible business people
Yeah.
because they're not trained to be business
Yes.
people. It's only when you dive in, as you have, I'm sure you are far better today in terms of your business acumen than you were when you started out on this journey because it's just not part of your repertoire, right?
Yeah.
And I think a lot of it is blind faith. Like, all right, I'll sign it, but it's the worst thing that you could do. I can't even imagine your counterparts that are basically stuck in these bullshit contracts.
Mhm.
They need a good attorney.
Yeah, and it's very frustrating that healthcare law is an elective. It's not a requirement. And so when a lot of people are not choosing to go into healthcare law specifically to help with this, we don't have advocates, for as many advocates as I would like to, rather, on policy, on making changes. So we have a louder voice to change the system. When it comes to non-competes, it's just ridiculous. Like, in what other industry do you have non-competes? Like, let's put it in healthcare. Amazing, because it's all about the patients. And so I get snarky because it's just, it absolutely is true. This is a level of irritation that we went to medical school and I had nobody say to me, like, you need, like, over at the dental school, they're learning that, like, dentistry is a business, but, like, we're learning about the kidneys today.
Yeah.
Yes. So I do feel that this is what younger people, that younger than me, medical students, residents, are realizing, that medicine is a business, and they're realizing a lot quicker than I did, which is awesome. But it's just, it absolutely needs to be a part of medical education where you're going to be a service provider. You need to be trained in business, period.
100%. And not just any business, it's 20 cents on the dollar business. It's 5 trillion. It's a $5 trillion economy,
Yeah.
essentially. So it's mind-boggling that physicians would find themselves in that type of a predicament after all the school and the training and et cetera, et cetera. So tell me, give our audience an idea of a day in the life before and a day in the life today. What does it look like?
So, a day in the life before was very much like you have to get there before the patients get there so that you can get a head start so you won't get behind in the day. Like pre chart what you can, read the notes because you haven't seen this person in a year and you don't remember who they are or what they take.
How far did you live from the facility that you worked at?
So since we moved to Arnold after residency, we've been very lucky. Like the farthest I've gone for work is 5 minutes in a car, but we used to walk to work. Our clinic that we own now is physically closer, but it is not. I would never recommend anyone walking on Highway 4 ever, even with as much protection as you could muster with lights and whatnot. But so we drive to work. Our work drive right now is a 2 minute drive. Our work before was probably, I would say, like a 3 minute drive, but we could walk to that clinic. And then we had a clinic before the one we own now that was a 5 minute drive. So I'm thankful I'm not in a 40-minute commute one way and traffic. Like
And even before, when you were working for the quote unquote system, you were close,
that was
right?
what was about 3 minutes away. Yeah.
So, what did a day look like? What give us just a glimpse into a day in the life? Your alarm goes off at what time?
So back then it would go off probably around 5:30 and then I'd get to the clinic around 6:15 to do all of that prep before the patients got there. Our first patient would be scheduled at 8, which is also when the doors open, so that always made a lot of sense to me. Like, great, let's schedule a patient right when nobody's here.
Right.
Amazing. And then after vitals are done, that already puts you back 15 to 20 minutes. If that patient arrives on time, they don't need to fill out extra paperwork. The tools are working, the people are ready to do the vitals, like all the things would start off with a chaotic day that was expected every single day.
And is
And then
almost
in
guaranteed to start backing up,
yes,
right? So so
100%.
that so that you're falling behind, you have people waiting in your waiting room that are aggravated because especially if you have business people like me where I have an ego and it's like, "Hey doc, my time is money too. I'm
Yeah.
going to send you an invoice." I'm sure you've heard that before, right? So it's got to add just like it's a pressure cooker, right? You're going throughout the day and the delays are inevitable and people start backing up.
Mhm. And after that, it would be like who's on my schedule. And a lot of it was physicals. Like I would see a lot of people who, especially Medicare beneficiaries, they'd come in for their one annual physical. And I would clarify, this is the one where I'm not supposed to touch you or listen to you. This is the like talking physical. And they're like, what do you mean? That's not a physical. I'm like, let me pull up CMS because that's what this is. This is the talking physical. You have
Right.
to come back for the other physical. And they're like, well, I'm not going to do that in some cases. And it was just
Ugh.
like, I really want to take care of you, but like what I'm translating is that you are doing what your insurance covers. You're not doing healthcare. And I really want to do healthcare, but I can't do healthcare because you won't come in for that. So that was one level of frustration.
Sounds friggin'
And
exhausting.
yeah. And another level of frustration is, well, Dr. C, we had to like triple book you. And I'm like, what? That's fun. And so when you are like you are a person who is in family medicine trying to help out with people's healthcare and prevention, and you're literally your mind is split because you're like, all right, so I know that I have to see you. I know I have to document your chart. I know there's someone waiting in the waiting room. I know that I'm 45 minutes over. I know that they're going to be angry. I know that I have to breastfeed. I know that people are adding more people to my schedule at the same time slots. I mean, it literally is just a never ending stress ball. It's like, it
Holy
is
shit.
ridiculous how anybody survives in that for so long. But I think it's definitely person to person. Like some people, they're just like, yeah, it is what it is. And some people are like, I meditate and take a walk during lunch and whatever coping mechanism, great. But for me, it was like, I if I have to do another Medicare physical, I will die. Like I will leave medicine and die. And it's like nobody prepared me for the frustration of not actually being able to be a doctor. You just have to like physically be there so you can process those goddamn codes.
Holy Jesus. That is a lot. That is just a lot. And so, on average, how many folks would you see a day, would you say, in the system?
So I would say like probably 9 to 11 and a half days. So 18 to 22 in a full day. And some of my colleagues see more. One of my physician colleagues had his colleagues in his clinic call out, and I remember the story. He said there was a day I saw 80 people and one of the babies that he saw coded while he was in this clinic, and I'm like, this is the crazy. Like my numbers are not as crazy as others, but it's like that's where again the numbers don't equal the experience and they don't equal the care that we were delivering, because my visits, like my patients who followed me to my private practice now, they're like, I used to wait in the waiting room like an hour and a half, and I used to be so angry at you. And I'm like, I know, but you also know that when it was your turn, I would give you the exact same care as the person that you waited for.
Right.
So
Right.
they would like quickly forgive me, but it was a layer of guilt and shame of like, why can't, like, how do I be more efficient? How do I fix the problem?
Right.
Because it's not the problem is the system. The problem is you, the doctor, who can't go faster.
Right. And not to mention, you need a bathroom break. You want to
Oh yeah,
choke
no, no.
down a morsel of food, heaven forbid. Probably next to impossible in an environment like that. So
Yeah.
your alarm goes off at 5:30. You're in the office by 6, prepping for patients that come in at 8. You go through the gauntlet of the day. What time are you getting out of there?
So this is where you like for me, I needed time to decompress. So I would like chat with my office mates about like how did things go, like what's going on, what event is happening at Disneyland, like anything to get away from doing the charts. And
Mm,
so that for me, that habit resulted in me having to do, I hate the term pajama time, but it's all of the work that you do that you don't get paid for, because
mm,
you're sitting there trying to finish charts that you didn't have the energy or the bandwidth to do like while you were in the 8 to 5 hours. You literally have to like finish them in 72 hours was our turnaround time, or else you wouldn't get paid. And so it's like, again, like it had nothing to do with quality of care. It was like, you just got to get your notes done. That's the game. Great. Like that's it goes back to why like female physicians may code less. It's like, I got stuff to do, man. Like, just get it. Like, I just need to turn in the note. Great, let's do it.
wow. So 12 to 15-hour days, not uncommon.
No, I would say that like that's very fair, just because especially before we had kids, it was causing a lot of friction in the house. Also, like, hey, like I'd love to, this is before kids, like go see a movie or like go on a date night. And it's like, no, I gotta finish my notes. It's like,
Oh, great.
what is this? Yeah.
That's sign me up. That sounds like fun. Oh, God. This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. All right, so fast forward. You're like, take that contract and stick it where the sun don't shine. We ain't signing it. What do? You huddle up with your husband, and what do you say? We're going to do this? What are we going to
Yeah.
do? Like, whose
Um,
idea was it?
yeah. And I totally forgot to finish my whole story as to the day the Band-Aid, like the day the
The straw that broke the camel's
yeah.
back.
So when I got this contract, uh, letter that was like, you're either going to sign or we're going to fire you. I was 28 weeks pregnant with my second child. It was 2:45 in the morning that I remember being so like all of the expletives by this letter that I shot up like pregnant as all get out, and I sat on the bathroom floor and I was like, I'm creating a podcast to talk about direct primary care, because to put it into context, 2 years prior to that, I had an orthopedic surgeon, a local orthopedic surgeon, tell me, Marielle, you should look into DPC. And I was like, what even is DPC? And so I didn't really get it. I did not get it, but I went down the rabbit hole like Neo following the rabbit in the Matrix of person connection conference that really helped me understand DPC. And through that, I had really heard these stories of similar to how I talked about Amy Jorgensen and doing physical therapy in the homes of these kids. I would hear doctors very vividly in my head. I remember like these doctors talk at conferences or one-on-one with me about what their lives were that was so different from the fee for service model and so exactly what I went to medical school to do. And so at the time that I was pregnant and with this like, threat of being fired, I was saying to myself, that's what I need more of. I need to hear these stories more. So that's the time that I like physically at 2:45 in the morning whipped out website, bought a domain, made a logo on Canva, like started a podcast. Had I ever done any of that before? No, in terms of the podcast part. But I was so pissed off and that was the way it manifested. And hearing like I stayed in maternity leave while I was listening to doctors and hearing them as I was interviewing them for my podcast. And by the time I got to returning to work, it was a how you doing? You okay going back? We're gonna have to sign this contract. And so I don't remember the day. Like I could find that on my email, but I basically sent them like the shortest email ever of I quit. And they were like, what? Like they totally were taken aback by that. And my husband and I thankfully we financially were able to say like, okay, if you continue on at the clinic and I build this practice, it can be a bridge to going completely independent for both of us. And
Mm.
so that was the plan and it worked for about 2 years, a little over a year, a little over a year. But in California, AB 890, I think is the bill. In 2023, January, it went into effect where a nurse practitioner with 4,600 hours of supervised care, quote unquote, could be a doctor in the state of California, basically, like unsupervised, like have a free for all, no medical degree, doesn't matter. And so what happened was that my physician husband's role was eliminated. We don't need you. We don't need to pay top dollar for medical training. We'll just have the nurse practitioners and PAs run the system.
Wow.
And so what happened is when my husband's role was eliminated, our community no longer has access to a full scope doctor who's able to see you if you're pregnant, if you need a procedure, if you need to see someone who's trained in taking care of all of these things. There is nobody else. My husband and I are one of 45 licensed people in the county of Calaveras, and we have been the only two since 2015 that are full scope family medicine in the entire county. And so if you're pregnant, you can see us or you can go to a different county if they'll take your insurance or your Medi-Cal. But if you were seeing him before, you had access if you were pregnant, if you were all of the things, because he still took insurance. But now that he got eliminated, like that's what's so wrong. And I wish that our community spoke up more about this is like the community was denied access to a physician who was able to take care of all of the things. And I mean, yeah, we're not ICU doctors, we're not surgeons doing lap choles, but in terms of the primary care clinic, the function of a primary care doctor, they no longer have access to that because the corporation made a money decision.
Mm. Wow. What horseshit. Utter horseshit. And so give me an idea. What's the population of this community?
So on the sign, it says about, I think, 3,800. So 4,000 people ish. But what I will say is that when the pandemic hit, a lot of people like bought out all of the vacant properties here. So we're like 45 minutes from the ski slopes. And the thing that they say in corporate medicine is you're 2 hours from everywhere you want to be. And that's Tahoe, Yosemite, Sacramento. Like I can get to the airport, Sacramento in 2 hours. So we're at a 4,000 feet elevation also. So it's a very small town in terms of there's one lane on the highway in each direction. We have one big market. We have a Dollar General. There you go. Open till 10 p.m.
Yeah.
when it's good weather. But we have a very small town feel in our community because like when you are in a medical desert and when corporations are not actually in the game of taking care of people, people tend to take care of each other. They don't go to the doctor. They're like, I read this on Google or I saw this on social media. You should try this. Or they'll use like, let's just put alcohol on that wound. Like just treat it. Maybe we'll sterilize it. Like we see things happen that are like, if you had access to a doctor, you could get sage medical advice rather than having to rely on this anxiety of healthcare experience that a person goes through when they're like, I don't know who to turn to. So I'm going to do whatever I can to survive. Like anybody would do that in dire straits. But it's like that should not have to happen when, like you said, we spend a bunch of money on like the healthcare of our country, and yet people don't get basic needs met.
Yeah. And they not only don't get basic needs met, but it's just the quality of the care that they're getting is so subpar. And that's not to say that the physician is delivering poor care, but outside of the actual medical care, which they get so little of, the patient experience is abysmal.
It's terrible.
So,
Yeah.
I'm in New York City. I'm a Queens kid, right? If I go out and I have a major health insurance carrier on my ID card and I try to set an appointment with my primary care physician, good luck getting an appointment within 6 months. Not
Mhm.
going to happen. Typically, not going to happen. And so we have the privilege of paying tens of thousands of dollars a year for this coverage. It's subsidized by my wife's employer. She's an SLP. She's a bilingual speech language pathologist, and she works in a preschool setting, and that's where we get our health care. And she by the way was one of my biggest critics when I started down this path of we don't need traditional insurance. There
Yeah.
is a better way. She was like,
Yeah.
you could pry my United Healthcare card out of my cold
Out of my
dead
cold dead
hands.
hand.
And that is the mentality. That's
Absolutely.
what we're
Yeah.
up against. But the reality is United, Blue Cross, Aetna, you name it, pick a flavor. They're not delivering one iota of healthcare. They are insurance companies. And the trouble is we have a system where we really have lost our way. We've lost the relationship with our physician. I go in to see my doctor. He doesn't know who the hell I am.
Yeah.
He doesn't have the first clue. And part of that is okay, your employer changes, your insurance carrier, maybe a doctor that you had seen for years is no longer in network. It's just not affordable to do it any other way. And so I think that's the predicament that many, many folks are in. But there's so little education when it comes to your layperson, just
Mhm.
understanding the basics. What's a copay? What's a deductible? Why is this important? What is the real underlying insurance? What's backstopping me from financial ruin? And I think that's really where the rubber meets the road because the big cost driver in healthcare is not your primary care physician. It's all of the stuff that kind of cascades as a result of the decisions that you make as an individual to feed your body. What are you putting into it? What is your lifestyle and your activities and your habits like? Is your physician talking to you about any of that stuff? Now, to your credit, it sounds like your organization is on top of it. You're reaching out saying, hey, you gained a few pounds. What the hell is going on?
Yeah.
Right? That doesn't happen in a traditional setting.
No. And I mean, like, literally, the patients I saw today were all like 80% of what I talked about today was lifestyle. For example, if you have a family and you're a family doctor and you take care of everybody in the family and the health history of the adults, the parents, and you say, hey, like for an extra $8, can we check your kids' blood work? Because we're doing the blood work anyways, because I don't know what their cholesterol is, but I do know that I know your cholesterol and your husband's. And that kid comes back with an LDL of over 160.
Mm.
And I'm able to start talking about lifestyle changes to literally make an impact in the morbidity and mortality of this child. I could never do that in fee for service because when did I ever order a blood test for there was no reason to order it other than I just know the parents' blood and I actually know the cost of what it actually costs to do a lipid panel.
Mm-hmm.
If I tried to get insurance to cover that, no, we don't
Right.
do that. And then if you don't do it, the cash price, if you don't use your insurance, people don't even know what the cash price is. And so, yes, the lack of transparency is ridiculous. But when it comes to the patients that I saw today, it's the way that I'm able to talk with them. I also love in this model now where it is so personal that like there will be things that I'm like, I didn't write that down or I can't find it in my notes, but I know I wrote it down, but I just remember this detail of like, hey, remember when this happened and you did this? And it might be 2 years ago that this happened, but because I'm able to not be so stressed at work, I'm able to just be with the patients. And
Mm,
that is amazing. And so when it comes to the preventative things, again, it goes back to there's no preventative code. So there's no incentive for us to do better healthcare. We want to do better healthcare because you're right. It's usually not the physician, it's the system that they're working in. But
yeah.
it's like when you have no incentive to do better by them. And we talk about value-based care. Value-based care is like you put lipstick on a chicken's butt or whatever, and it's still a chicken. It's like that's exactly what value-based care is. And some people will say like, "Oh, DPC is value-based care." I'm like, DPC is primary care. Let's just call it what it is. And
Right.
then you can take your value-based insurance-driven stuff and you can call it whatever you want to, but that's not what direct primary care is. And so that's the world that I'm in now of like really being able to see the stark differences between what I did before and what I'm able to do now.
Well, so to use, and I'm not a huge sports guy, I'm a fair weather fan and stuff like that, but to use a sports analogy, you're skating to where the puck is going to be, right?
Yeah.
That's what the great Wayne Gretzky would
Yep.
say.
Yep.
And I feel like the people that are in the traditional system, they're skating to where the puck is. So they're behind the curve. They're basically looking at symptoms, and the thought process is let's write a script, address the symptoms, and on to the next. And
Mhm.
I think that's it's a terrible way to administer medicine. And again, that's not a knock against the great men and women that chose to be a physician as a profession, but it's the way the system is designed, and they're doing the best they can with what they have. So it's got to be incredibly liberating for you today. Are you still writing those codes? Is it just like, like force a habit, like you're just conditioned to write those codes in your charts, or is there none of that anymore? What do your notes look like compared to what they used to look like?
Yeah, note bloat is what is the term that we would use for 14-point review of systems, negative otherwise as stated in the HPI. It's like never have I written that in direct primary care. That does not mean that the care is less quality. It's much higher quality because we're really focusing on like what actually matters. Do I need to look at a person's toe when they have a skin spot on their hand? I'm going to say pretty much in all cases no, but like if I had to do an ankle brachial check to check their pulses, even though I'm trying to freeze a stuff on their skin, it's that doesn't really matter for today's visit, but I still have to document it if I want the insurance to reimburse me for that. Was the game before. And so now the utility of codes is that when people wish to use their insurance and remain in the game for lab draws, mammogram orders, seeing a specialist who takes insurance, then those codes will come into play. But I
Hmm.
also have to go to Google to look up like what's the ICD, whatever. I mean, there's certain ones you're like, I know what skin lesion is. I know what diabetes is because those things are so you can't get stuff done unless you have these certain codes. But in
Right.
terms of what is the code for the codes change also. So I'm frequently relying on I have to look up a code if I need to use it for the patient to be able to use their insurance for not my care.
Mm. What percentage of your patients would you say have traditional insurance versus
Mhm.
don't?
Yeah, so right now, I believe 100% of our patients have insurance. I joke that some of them have like gold platinum plans because they're like, "Oh, I have this and that." I'm like, again, insurance is not healthcare. Like that's
Right.
probably 5 minutes of a lot of visits of my current practice. Like, remember, when you have insurance and they didn't cover your mammo because it's a 3D mammo and they only cover a 2D, like they're only covering the lesser of the 2 mammograms in terms of actually preventing cancer. So that statistic has not always been the case. We have people who have Medi-Cal for insurance. We have had people who have been uninsured in our practice, and we are agnostic to what insurance a person does or does not have. And I proudly say, if you're a human being, I am a human being doctor. Fantastic. Let's take care of you.
Yeah, that's great. And so Is it a subscription model? Is that what you have? So what would a patient or a family expect to pay
Yep.
in order to have your care?
Yep. So my direct primary care clinic, we do a membership model. And so we do not bill insurance. There are some hybrid DPCs out there. But my clinic is based on age. So if you're a younger person, most likely less health issues, chronic healthcare issues, the visits are either structured like child well visits or it really in when you have acute things. The older a person gets, the rate goes up. And so our rates start at $69 for a baby up to 12 months, and then 79 for 1 year to 18 years, 19 to 42, I believe. It's 69, 79, 109, and 149. And then if you're over 100, it's $1. And so after stripe fees, it's 67 cents. I think I calculated that once, but my patient who is in her 90s said, "Dr. C, I'm going to live to 100, so my healthcare is $1 a month." And I'm like, "I love it. Let's do it."
That is fantastic.
Yeah.
And so let's suppose that you have a patient that is seeing you, they're under your care, and well, let's just talk about some of the things that you can do versus can't do. So you're not, I'm guessing you're not like for acute trauma and stuff like that.
Correct.
So do you deliver babies? Kind of where do you start and where do you?
I stopped doing hospital medicine when I left residency. It was
Mhm.
not my bucket of joy. I was doing colonoscopies until the corporation pushed me out of doing colonoscopies. My turnaround time to get people in for their colonoscopy, screening colonoscopy, was 1 to 2 months. The standard of care with the GI doctors was 8 to 12 months. So if you died of colon cancer before then, sorry, not their problem. But what happened was the corporation would cancel my patients without them knowing, without me knowing, even though they had already prepped, some were already there at the facility, because it was more expensive to have the staff cover the few patients that I saw who were exclusively on my panel versus, again, taking care of patients.
Wow.
So I used to do colonoscopies. I used to deliver babies, but I need sleep. And especially after having kids, I needed sleep. So I intentionally stopped doing hospital medicine and deliveries after residency. But everything else I continued. I stopped colonoscopies, I want to say 2019. Is that right? Maybe 2019. And then, but everything else I still do. Like
Mm.
I biopsied a scalp the other day and I ultrasounded a person after a trampoline accident. And this is what we went to school for, is like literally just like whatever it is, it's like, let me use my medical training to figure out if I can take care of it or not, or if I need to take care of it to a certain extent while you wait the 6 months to get into your cardiologist for your active palpitations. And then I can also extend care by doing virtual consults. So that's what I really enjoy, is that, again, going back to like your question about wearable devices and whatnot, it's whatever tech, whatever tools, whatever I need to get the job done that is affordable and accessible for myself and my patients. This is how we deliver healthcare.
And then if someone needs a referral to a specialist that's beyond your scope, are you actively involved in making that referral or are they left to go check their network and all of that jazz?
Yeah, so definitely it depends on the insurance that the person has. With a straight Medicare plan, you can self-refer, but with you, if you have Medicare Advantage, definitely the network is going to be smaller. If you have Medi-Cal, it's going to be way smaller in California for access, who in terms of doctors or clinics who will take your insurance. But it's the same in terms of when a person needs a referral. I'll usually ask, like, do you have anyone in particular that you'd like to see? Or if they have nobody and I do have a recommendation, like this is the person I would take my own family, I'll give them options. And then again, I will try to do what I can virtually with consults before I send them to referral, or very frequently as they're waiting for one. Because if there's something like, I don't know if there's any other labs or any other like biopsies that I can do or whatever, I'm able to run that by specialists with their approval. Like, yeah, like go ahead and talk to another doctor, because again, like the access to care here is so minimal. We're in such a medical desert. The corporation has done nothing to maintain the culture of keeping it local. And so we've lost so many physicians, especially in primary care, since we started the job. 2015 is when we started here. Rheumatology doesn't exist here. Like I can go down the list of people who there might be specialists on the website. I love that. Like when you look at a corporation's website, they have great marketing teams, lots of money there. They'll put like, oh, we have vascular surgery, we have dermatology. It's like, no, actually, you don't. You have people who are remote. You might have like the tech here, and that's what they're calling like the whatever center, or they'll have people coming in from out of town. But like if they're not in town, because this is not where they usually work or live, don't cut yourself with a chainsaw, because we don't have any vascular surgeons anymore. It's stuff like that where they've done so much to destroy the medical culture that did exist before it went very corporate, where we were very like, we were encouraged to talk to each other, cross specialties to coordinate care. And now it's like, just keep your head to the grindstone, get your codes done and turn them in 72 hours and be done. Like go on to the next person.
Wow. How about, do you have like freestanding radiological facilities where you could send people to get an MRI at $400 or $500 instead of $5,000 in the local healthcare system,
Yeah.
cash pay, that sort of thing?
So sadly, our local nonprofit charges 400% or more on the actual cost of whatever it is. And they do not offer anything lower than that for cash pay patients, because as many people in my world know, but as many people in the grander population of America does not know, you do not have to use your insurance to pay for healthcare. And so when it comes to radiology, I specifically look for places that will do cash pricing. So I can literally present like a restaurant menu. This is the price of the MRI. So, for example, I had a patient who needed an MRI of the hip, both hips actually. And instead of getting, oh, you have to do physical therapy and fail that after 6 weeks, and then we'll try this approved injection in the area. And then it's like, for $465, I can get my thing done within a week. And so within 6 months, the diagnosis to total treatment, which required surgery in this case, was done. And that was because it was like, it's like, again, I'm very big on like real life examples in my life. It's like, I have not been to Chuck E. Cheese lately, but like Disneyland is a real thing. It's like when you pay for the Genie Pass or whatever it is now, it's like you pay extra money to get better service there. It's the same thing in healthcare. It's like, instead of paying top dollar for insurance, just like the conversation that you and your wife had, it's like, let's think about this realistically. Like if I'm fairly healthy and I'm not going to need a lot of things, like why don't I just do cash pay for my labs, $65 or less, and not have to do an insurance plan that's going to be super expensive and allow me access to everything as long as it's in network. It's like people are waking up now to the ability to actually like craft their healthcare budget for healthcare. And that definitely includes, I mean, excuse me, that's definitely driven by the ability for doctors like myself to be like, okay, your statin actually costs $87 for 1,000 tablets, or you could pay $20 for 30 under your insurance plan. Which one do you want to do? And they're like, wait, but I have insurance. And again, this is why insurance is not
Yeah.
healthcare is like a big theme of my visits in a lot of time, in a lot of cases. But when it comes to the care, it's just so different.
And is a statin even appropriate, right? So I interviewed Dr. Jack Wolfson, America's #1 natural cardiac doctor. I think that's his moniker anyway. But he is married to a woman who was a chiropractic practitioner. And she really spun his world 180 degrees. And now he's gone really the very holistic route. He's still a practicing board certified cardiologist who can prescribe medicine, but his go-to is not to prescribe Lipitor or whatever statin, pick a flavor. When I interviewed him, he said, look, your body manufactures cholesterol beautifully. Get your ass out into the sunlight and expose your skin to sunlight and vitamin D, you'd be amazed at what happens. And so I really think there's so many layers and complexity to what's wrong with healthcare. But I love your story and your journey, and thank you so much for sharing it with our audience because folks just don't know. And to your point, I think it's very common for people to say, but I have insurance, right? But
Mhm.
if you look at an MRI or a major diagnostic exam, if you go into a healthcare system, the bill charge might be 8 grand for a test like that. And so if you can pay 100% of 500 or 1,000 as opposed to 20%, which is your co-insurance on 8 grand, guess what? You're ahead of the game,
Yeah.
right? So part of it is just being a student of the game and knowing
Mhm.
that you don't have to play by their rules for sure.
Yeah.
So, how do people find you?
Yeah. So, my podcast where I interview physicians just like myself doing direct primary care is at mydpcstory.com. The podcast is called My DPC Story for direct primary care. That's the main way to find me. And then, from there, I have a about me page like I do speaking and consulting and whatnot, but I also have created something for the DPC community called the DPC directory, where it's like an Angie's List for DPC, because what I really got frustrated with was when people were looking to do this journey into DPC, they were spending their nest eggs that they had saved up for on solutions like marketing agencies to develop a website that didn't understand DPC. So it's really an extension of what I've learned people need from the podcast to be able to delve into a community of people who understand DPC. So that's not the thing to talk about. It's okay, how do I deliver this to my community? If it's I need to get a wearable device, or I need to get a person to help with the legal papers to protect what I'm doing, whatever it is, but that everybody in this community is coming because they understand direct primary care at the baseline. So it's that those are the main places to find me, but the podcast is weekly and we're just about to wrap our fourth season.
Wow, congratulations to you. So yeah, we'll include anything that you'd like in our show notes so people could find you, have access to resources.
Sure.
And so that's available for download on YouTube. And naturally, the podcast is Apple, Spotify, wherever you listen. But Dr. Concepcion, so cool for you to join us. And I just want to say thank you for not being a follower and for being a trailblazer. And we don't have to take it anymore, folks. We don't have to take this shit anymore. And so, good doctors like you that are leading the charge, I applaud you because it takes courage to break away from the system, get out of your comfort zone, throw the bird up at the man and say, no, we're not signing your bullshit contract, and doing it your way. You're doing good work, you're doing God's work. And thank you so much. And thank you for sharing your story with our audience.
Thanks
Really,
for
really
having me,
appreciate
Ray.
it. Of
Yeah, thank you.
course. Folks, until next time, peace and love always. Peace and love always. Take care.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show and join us on the next episode.